Welcome, everyone. I'm Dr. Thomas Raff, the Associate Director of Urgent Care at Lancaster General Hospital and a family medicine physician. The program you're about to watch was from a live CME symposium that Dr. Allwater, Dr. John de Mornay, and I presented on January 11th, 2019 in Lancaster. We're sorry that you couldn't attend the live program, but the recorded version includes all of the information that was presented, including the question and answer session. For any additional information, please visit lghflu.dkbmed.com. Thank you for your interest in our program. I hope you find it informative and useful. Welcome to What's New with the Flu. This is a CME program that we're doing in conjunction with DKB Medicine, and we're going to be reviewing both what is happening with flu in our community, as well as state statistics and new developments in the management of flu with our guest speakers. We do have some basic shop stuff to just kind of get taken care of first. So those that came in, and welcome to those online, there is a pre-test and then there will be a post-test at the end. Those of you that are online will end up getting the post-test emailed to you. So to receive credit, you need to do both the pre and the post-test and then the attestation form. Those of you that are in here in the room, there is also a final form that is just an evaluation of the program. So you have 4 sheets in front of you. The final one is the evaluation that you do at the end. For the streaming viewers, as mentioned, the forms will be sent to you at the end. For questions and answers that you might have during the presentation, there is an email address right here. I'll give you a moment to write that down. That email address will appear at different points during the lecture if you don't have it written down now. And you can connect by Wi-Fi to the LG1 guest, and the slides will be sent to you by email in order to not use up natural resources. This educational support is supported by an educational grant from Genentech, but all the content materials have been developed separately and solely by the activity directors, the committee, and the faculty presenters without any influence from Genentech. Joint accreditation statement. This is the standard accreditation statement that we're all familiar with. The terms of CME hours, you're able to get 1 hour of AMA credit, and then, as we all know, physicians should claim only the credit commensurate with the extent of their participation in the activity. This is also part of a performance improvement quality initiative that we'll be doing here at LG Health. It's a wraparound project where those that are involved will be able to get 20 hours of double AFP credit, and the term begins today, and it is good for 2 years. So if you have interest in that and you are interested in the credit hours, contact myself or Dr. de Mornay. We can tell you more about that. This is also accredited for double APA for physician assistants, and that's good for 1 hour of CME credit for activities planned. And then, not to forget our nurse practitioner colleagues, this is also good for 1 hour of contact, and maybe even more importantly, for the very coveted pharmacotherapy contact hours, which are very difficult to get in the nurse practitioner world, from what I hear on the street. Okay, I want to go over our faculty. As mentioned, I'm Dr. Tom Raff. I graduated from the Medical College of Virginia in Richmond. I did my residency here at Lancaster General Hospital. I practiced in what has been voted the most scenic town in America, up the street in Lidditz. I then went on to do 20 years of academics at Tower Health, also up the road, while still living here in Lancaster. And for the last year and a half, I've returned to my home base and am working in urgent care as the Associate Director. We are also joined today by Dr. Jean-David de Mornay, who is a graduate of the Université d'État Haïti, or for those of you that don't speak Creole, the University of Haiti. He spent 10 years working in Haiti as a medical director in a regional area before moving here to the U.S., where he also went to the Lancaster General Family Practice Residency, and for the last 10 to 15 years has been working in the emergency room, both as a practitioner as well as doing education with residents. He has joined us full-time now, much to our delight, in urgent care, where he is involved in a lot of committees and is doing some great work. We are also joined by our esteemed speaker, Dr. Paul Allwater. Dr. Allwater is a graduate of Columbia University as undergraduate and medical school, went on to do his internship, residency, and fellowship at the Johns Hopkins University, and stayed at Johns Hopkins and is now the professor of the Cheryl and Ken Fisher professorship. He has done 33 original research contributions. He has reviewed at least 13 review articles. He's contributed to 30 books. He has edited 5 books. He has been involved in the development of at least 11 guidelines and protocols and expert opinions. He has done numerous teaching both nationally as well as internationally. He was the past president of the Executive Committee of the Board of Directors of the American Infectious Disease Society of America. But closer to my heart, he has also been an expert reviewer for the American Family Physician Journal and is the editor of the Johns Hopkins Antibiotic Guide, which is that little pocket guide that has been so indispensable to so many of us over the years. So with that being said, these are the requisite disclaimers about faculty disclosures. And now our educational objectives. So we're going to go over the CDC guidelines for vaccination and initiation of antiviral therapy. We're going to talk about effective communication techniques and how to address the issues that patients bring to you about why they may not want to be vaccinated. And then we're going to talk about emerging antiviral therapies. As you know, there's a new medicine on the market, so we'll touch upon that as well. So let's dive in here. I'm going to do the first part, influenza by the numbers, and that'll be looking primarily at LGH data, both current and retrospective. And Dr. Mornay will be doing prevention, diagnosis, and management, and addressing patients' knowledge. And then Dr. Allwater will be talking about the medications and the new developments and answering questions and answers. Okay, so influenza by the numbers. As we know, particularly those in urgent care, I feel last year was really bad. There was a total of 80,000 deaths nationwide. There were 185 pediatric deaths, and some of those deaths, many of those deaths were surprisingly not in children who had underlying diseases that were not high risk. Highest level of hospitalizations in decades, and primarily 50% of those or more were in the elderly. LGH data, our emergency room data as of this time, at the end of last year, which would be week 44 through 52, the red line is the CDC national baseline, and the blue line are the number of influenza-like cases that our emergency room saw, and you can see it starting to tick up at the very end of the year. And then these are the confirmed cases in the ED. If we look at 2 to 3 years worth of data, the blue season here is 2016, and then the yellow season, and I think we can all visually and emotionally remember this, is the rather brutal flu season we had last year. And then this is our current uptick in numbers up to week 1, which would have ended last week. So thankfully, knock on wood here, we have not had the kind of uptick that we had in years previous. Of the types of flu that we are seeing in the community currently, and this is this year, we're mainly seeing influenza A, just diagnosed a case with one of my partners yesterday, a small sliver of influenza B, and the vast, vast majority of this is outpatient, although we're seeing a small portion of inpatient. My suspicion is a lot of this would be replicated and very similar in almost every hospital in the nation, LGH just being a sort of prototypical hospital system. Confirmed cases of flu by age. For those, once again, the 16 to 17 year, the 17 to 18 year, and the current year, and you can kind of get a sense of the smattering, and of course the elderly have a much higher number. A little bit proportionally higher in pediatrics, the young pediatrics this year as compared to prior years, but probably not statistically significant. Vaccination status, 16 to 17, about 60% received the vaccination, and about a quarter did not. And last year, about 35% but the unknown category is much higher, and I don't know if that is related to perhaps the way that it was measured or the questions that were asked. It seems hard to believe that there would be that much of a drop-off. But one thing that is very persistent, and Dr. de Mornay will address, is that 25% of the non-vaxxers there. LGH flu cases, so if you were sick enough to get in the hospital last year, you were, and the year before, you were most likely to end on a med-surg unit. The pediatric unit, we don't have a pediatric ICU, so there's no ICU numbers there for peds. And then about 10% ended up in critical care or ICU. And then about 17% ended up in the observation unit. Those are the hydrate and they're better by the morning folks. And then if, in terms of location of diagnosis made, the ED was by far the majority. WBH is the Women's and Babies Hospital, our maternity hospital here in Lancaster. So about 1% of moms were diagnosed at their triage center. And this kind of reiterates where you would likely to be, but this is currently, so about 80% of our patients that have been admitted, 18 of them are in a med-surg floor, and then about 5 are critical care. And then the length of stay currently this year tends to be between 2 to 6 days. And then, as usual, you have 1 or 2 real outliers, probably someone with some very severe underlying respiratory disease that was unfortunate to get influenza. As of the last year of December, or the last week of December, this is the general CDC map, and we're considered widespread. And then looking at the state numbers, the purple graph here is the southeast region of Pennsylvania, so we're in the hotbed and we exceed every other region by a significant margin there. And then this is just the variation of pneumonia and influenza over the last 4 or 5 years. So with that being said, I'm going to turn this over to Dr. de Mornay to talk about prevention and diagnosis. David?
Good morning, everybody, and thank you for being here. A quick reminder, if you with us to our stream, streamcast, please email us your questions at lghflu@gmail.com. We are monitoring this email and we are ready to answer your question at the end of the presentation. What we want to talk this morning about is going to be very quick. We want to remind you that you're going to be seeing some patient who doesn't think flu is serious. These numbers would beg to differ. More than 5.3 million illnesses from the flu, and these are the last season, 2.6 million medical visits, and about 85% hospitalization. We would be a bit dizzy if we had to add the cost of these type of numbers to our health system. We don't have the best tool to fight the flu. We all know that the flu vaccine is not as efficient as some other type of vaccine we have, but we still don't have anything better, and the CDC strongly recommend the flu vaccine as a blanket for everybody older than 6 months old. What we need to remember is, beside this blanket, there are some categories that are specified that we should maybe make an extra effort to get them to receive their flu vaccine. But because you're young and healthy doesn't mean you don't need it. These groups, we have the list here, older folks, children, especially from 6 months to 2 years old, but 6 months to 5 is the wider range of sensitive children that we may need to help. Other type of metabolic diseases, people with any type of immunological weakness, pregnant patient, patients who are institutionalized, or healthcare providers who are in contact with these patients. All these, we would like to make sure they are vaccinated and protected. Flu symptoms and cold symptoms are so confusing and similar for everybody, I want to try to put it in one sentence that everybody can remember. Common cold usually have symptoms who are focused on the respiratory system. And the flu is more constitutional and systemic in the signs and symptoms you're going to see. It's important for the provider to understand that because it's going to happen very soon in the flu season that we won't be testing everybody any longer. Once we know what type of flu is active in the community, we're going to see the patient and go on our clinical judgment and treat these patients. And when you see more symptoms that are systemic, like fever, like ache and pain, and chills, you're going to find more of that with the patient who has the flu and more focused respiratory with the patient who has a common cold. And yet it's still going to be your clinical judgment, and we'll talk about how you make this judgment a bit later. If we have to look at the first case, we are wondering whether this patient has the flu or not. Let me give you a quick clue. It's a viral syndrome. It's a 19-year-old male who presents to the urgent care complaining of fever, cough, achiness, and nausea times 2 days. This 19-year-old said he is too weak to go to class. I'm sure we all heard that before. He had some sick contact in his dorm. On physical exam, he doesn't seem to be in distress. His temperature is 101.2. That's an okay fever. Blood pressure 112/70, pulse 104, respiratory rate 16. His ears are normal, including his tympanic membranes. Throat is mildly injected, a bit irritated. No exudate. Lungs are clear to auscultations. Now, the clinical questions is, when do you suspect this patient has the flu or not? Do you go through the risk assessment process to see if this patient is at high risk to get the flu or even high risk to develop some complication from the flu? And how do you diagnose? Are we going to do a clinical diagnosis, as I said, with our clinical judgment, or do we need to do testing? Which patient needs to be tested? And consider the complication, because sometimes you would see the patient when they start getting better, and then they say, oh, from last night, it's like I get it again. That's what we would call double sickening. Double sickening is always, I would say, a sign of complication. When you had some type of viral illness that start to mend and suddenly you hit again, that's when you know as a clinician something else is going on, and most likely you're dealing with some form of complication. And to protect the community, it's always a good idea to question these patients about who they are in contact with, where they are working, what kind of activities they are doing. Some people are more in contact with others, with everybody else than others, and this is a big factor in how the flu is spreading like a wildfire in the community. We have a list of all these diseases. I will spare you the reading of all of that. All these different conditions, including a high BMI, increase your chances of developing flu-related complications. I'm sure you all know that, and you can read that on your own. Now, let's talk for a few minutes about how these different diagnostic tests work. Most of us are used with the first one. That's the rapid flu diagnosis we use in the office, in urgent care. And this test is just checking for antigens. It would test for flu A and B. Usually we just do a brain swab. We have the result within 15 minutes. But as you can see, the specificity and sensitivity for the test is okay, but not great. We would want something better. If you look at the number in the last one, the PCR test, which is the best, is not really practical for a clinician. We know how rushed we are to go through the patients, and this test takes 1 to 2 hours. It's usually not something that we would use. Somebody like Dr. Order maybe would use a test like that when he really needs to confirm what he is doing so he can handle something complicated that we would throw to him. For high-risk environment, when we're talking about this patient, we assess that as well, assess what's in the community and what's in their immediate living area, if they are interacting with some high-risk group, and if they are living with high-risk individuals like pediatrics, elders, patients who have weak immune system for all type of different reasons, and if they are associated with people who did not get their vaccinations. One of the barriers toward treating patient and taking care of the flu is, what do they understand the flu is? What do they understand the risks are? And how useful do they think the advice and treatment we are proposing are for these patients? To assess some of that, it's a good idea to use the health belief model. And in this health belief model, we understand what the perception of the patient is. First, let me tell you, this is not a checklist that you're going to go through for the health belief model. You check this, then that must be what it is. But as a clinician, we are supposed, I hope that we all are, good listeners. And just during your interaction with the patient, just listening to the patient during the interview, most of these informations are already available to you. So if you have it in mind, you are already checking it in your head that this patient doesn't really think that there is a significant susceptibility for them to have the flu. Some people, I've heard it many times, oh, for the last 5 flu seasons, I didn't have anything. I can't get the flu, I'm fine. So this patient means I don't get the flu shot. I don't need the flu shot either. Perceived severity, they would tell you, oh, the flu is a bad cold. It's nothing, just write it out. Some are right, some are unfortunately very wrong. What's the benefits of the treatment and the advice we're giving them, and what would decide them actually to get their flu shot? What would decide this patient to be treated, to look for help to their primary care provider if they are actually sick? The patient's perception, we have this list from 3 different places, from the CDC, from Harvard Health, and Influenza specialist group. Some patients would tell you, as we just said, the flu is just a bad cold, it's not really serious, or they just don't get it, or even the timeline. I don't know where this study came from, but if by December you didn't get the flu, you're home free for the rest of the season. Nothing is more wrong than that. I'm sure you will all see that. Going outside in the cold, without your coat. And we heard so many mothers, they say that to their kids, oh, you have to wear your coat or you're going to catch a flu. All these are not exactly true, and there are no evidence to support this. Stomach flu is the flu, not really. And some patients would come to you because they need antibiotics to take care of the flu. And you're going to have to find a way not to give it to them and to keep them as a good friend. Good luck with that. Barrier to vaccinations. Some would tell you, I'm healthy, I don't have diabetes, I'm not on any medication, I don't need to be vaccinated. As you know, the CDC has a blanket recommendation for everybody older than 6 months. So if you're healthy, we're happy to hear that, and you want to stay that way, get your flu shot. Some people would say, oh, I had it in the last few years, I don't need it right now. Every flu season is different, thanks to mutations. Flu vaccine can give you the flu. So some people would say, oh, I'm fine now, I'm not going to get a shot to make me sick. So we are, as providers, have to have an answers for these patients and treat them with respect, but at the same time respectfully disagree and try to provide some more accurate information. Some patients would agree with everything they tell you, but everything you tell them, but they still think, I want everything all natural. I'll get some tea. I don't need to be treated, when these patients are already developing signs of complications. We have in the community some of the belief that patients may think home or grandma remedies they can use, but there are no high-quality evidence to support any of that. If we look at this second case, that is the classic case you would have in an emergency room or in an urgent care, maybe 15 minutes before closing. A 2-year-old female patient with fever, cough, headache, and achiness for the past 24 hours. Symptoms seems to be getting worse. The parents live on a farm. The child is exposed to poultry, swine, cows, regular farm kids we would have in Lancaster. The parents received the flu shot 5 years ago, but they got sick from the flu shot, and they are not into flu shot and have not been since. This child obviously has not received the flu vaccine. And the mother, possibly believing in everything natural, is treating this flu with a tonic that she most likely cannot tell us. This is one of your cheat sheets as a practitioner, where you can integrate the health belief method, a model, into a shared decision-making during your conversation with the patient. You can look at the patient's age, ethnicity, and go through this motion, but you don't have to go through it from beginning to end, as I said, because these informations you collect during your conversation with the patient already put you somewhere on the map. You already see what's the perceived conception, seriousness, or susceptibility of this patient, and you know in which way you can start moving to see if we can get to a useful decision. Because at the end of the day, that's how you can help the patient. If they need treatment, get them on the right treatment. If they don't, avoid to get them on a treatment that they don't need, that ultimately may actually harm them. But remember, the goal with all of that, when you go through that, is to get the patient to understand they need a yearly flu shot, and they need to get medical care as soon as they start having serious symptoms. Best case scenario, 24, 48 hours into it, we need to get the medications in, because these medications, they really don't work. Antiviral medication, Dr. Auer will talk about that. They don't work like antibiotics, so the sooner the better. When you're trying to talk about the health belief model and integrate it into your health decision making, we have here the list of perceptions of the patient and a group of questions, and how do you phrase these questions that you can try to talk to the patients. Again, this is not a checklist. You don't have to ask every question and put a check mark next to it. But if you have to ask this question, if their perception is not clear yet to you, these are good suggestions how you can ask this question and get an answer that you can rely on to make your judgment call and propose a treatment plan. These 2 slides, they are given to you today, and there will be 2 in the ones we email you, so you can refer to them as needed. You can make it a cheat sheet in your office, and that may help in the way you interact with your flu patients. Okay, thank you very much. Now, Dr. Auer will come and continue with all the treatment and medications. Thank you.
Good morning, and I wanted to thank Dr. Mornay and Dr. Raff for the invitation to travel north of the Mason-Dixon line today and speak with you today. As mentioned, I'm at Johns Hopkins. I'm the clinical director for infectious diseases, but I also do primary care, which I think keeps me honest. So I not only talk, but I have to walk the walk here a bit as well. So there's another case here that I think will help frame this a bit. This is a woman who, again, as Dr. de Mornay mentioned, has systemic complaints. So it's not just localized to the head and neck. With some cough, she's only been sick for about 2 days, but also has a young son at home who also is cold. Did get the flu immunization about a month earlier, and she's otherwise not ill. But, here she's presenting at 2 days. And as mentioned, our current influenza immunization is by no means perfect. This is not like the measles vaccine. You're not 100% protective. But it is the best that we have, and it's quite variable on a year-to-year basis at how effective it is at completely preventing influenza. You see the range there of 10 to 60%. But what I usually tell patients, because there's been some press that says the influenza immunization doesn't work, is that it probably gives your system a head start. You are already been primed a bit so that you can sort of have some pre-existing antibodies or antibodies that rise to the challenge more quickly. And what is true, especially for people at higher risk of influenza severity of illness or complications, is that it reduces the chances you're going to feel ill enough to go to the doctor's office or end up in the hospital with major complications or death. So yes, it's not something that works 100% of the time, and I think that's some of the messaging that's often difficult in this case. And last year, the vaccine wasn't great. And it's sort of interesting why. You can see here on this particular slide that H3N2 was the bulk of influenza last year. H3N2 has really been the seasonal influenza strain that has made most people very ill or landed them in the hospital. Of course, any of the strains, including the pandemic H1N1 or even influenza B, can do it. But this was the majority, and the vaccine worked least well against H3N2. And what we're beginning to understand as we're doing more molecular testing is that when you're making all these vaccines in eggs, very old kind of production system to generate the vaccine may have mutated in the egg supply and wasn't quite what they thought it was going in as to what was coming out in the flu vaccine production. So obviously we have strides to go, and there are efforts to make a universal influenza vaccine, but you're going to be seeing patients with influenza. So if you see patients with influenza, there are antiviral medications that may offer your patients help, which we'll talk to. Luckily, for the drugs that we are using, there has not been a lot of recent viral resistance to the commonly used drugs, which is, of course, predominantly Oseltamivir, or the old trade name was Tamiflu. And last year, there was really only 1% incidence of resistance to Oseltamivir, so we haven't really seen a lot of circulation. And I always say in Japan, if any of you have been to Japan, the highest rates of Oseltamivir use in the world are in Japan. People take, on average, almost 2 courses of Tamiflu each person a year. They are really afraid of influenza there. But there's still very little resistance despite this heavy use. But it's still a concern that if we overuse a drug like this, that resistance will develop and it won't work. For those of you who are of my age or older, you know you've used amantadine or rimantadine in the past. The circulating seasonal influenza viruses are almost uniformly resistant to these compounds and have been for over a decade. So this patient mentioned that you had an influenza immunization just a month ago. So you sort of feel, oh gosh, here she's still got the flu. Febrile, tachycardic, has some elevated respiratory rate, and her room air oxygenation saturation is a bit worrisome at 88%. On exam, she doesn't look completely healthy, and she has some wheezing on exam with diminished sounds at the lung bases, and a rapid flu swab, as Dr. de Mornay mentioned, an antigen test is positive for influenza A, and she has an abnormal chest x-ray. So in this particular situation, this sort of frames a little bit of what we might do for antiviral treatment. And Influenza itself can cause a severe pneumonia, a viral pneumonia, and complications that could include ARDS. But there's also the double sickening component where you can get a secondary bacterial infection. For those of you that need to take medical tests and boards, you know that MRSA and Staph aureus is often the correct choice because staph seems to enjoy setting up shop in lungs that have had influenza, but also the pneumococcus. So those are often the two most common. What we know from a lot of studies since the first anti-influenza compound came about is that early use can reduce complications in children, for example, avoiding earaches, pneumonia, or severe complications that would require intubation. But Dr. Mornay mentioned it, and I think a lot of patients have this misconception that antiviral medications work like an antibiotic, and they really don't. They work very differently, and we'll talk about that in a moment. When you're looking at the world of antiviral studies, most of the data comes from Oseltamivir and Tamiflu. And those studies, the initial ones, the randomized controlled clinical trials, compared it to placebo and found that if patients got it in the first 48 hours of onset of symptoms, that their illness reduced by about a day, perhaps up to 72 hours, led to some benefit as well in other studies. But the Centers for Disease Control, those of you who work here in the hospital, has sort of a blanket recommendation that anyone with an influenza-like illness or concern for influenza who's ill enough to be hospitalized or has some of the high-risk conditions that have already been mentioned should get an antiviral compound. And I think that view is framed by the fact that the antiviral drugs are fairly benign, they're not terribly dangerous, and they may have some benefit. But studies have really not found wholesale improvements if you use the drug after 4 or 5 days of symptoms, but the recommendations are still to use the drug because they really don't work quite as well there. So, you know, we've been talking about these drugs and who here has prescribed or taken themselves Oseltamivir? So probably most people. Who's used any other anti-influenza drug? So that's, one person, okay. So we're mainly talking about Oseltamivir. And these neuraminidase inhibitors, how they work is if you are a virus in a cell, the neuraminidase inhibitors inhibit the cleavage so the viruses cannot bud out of the cell and infect other cells. So if you're at day 4 or 5 of illness, pretty much the virus is spread through most of your body. It's unclear that preventing the virus from emerging from a cell is going to really stave off infecting new cells. So this is very different than what you would think as an antibiotic where you're sort of killing a bacteria. Here, viruses aren't alive, right? They're not, they are sort of parasites of cells. So the Oseltamivir works best if you give it very early before the large number of cells in your body have already been infected. So it's very important to give it as soon as possible. The problem is a lot of patients don't come in until day 4 or 5 or further in their course because they're toughing it out early on. So this is part of the limitations of it. As mentioned, in hospitalized populations, there is advice to use it as much as possible if you have suspicions, but the ability to affect improvement is probably limited after 4 to 5 days after onset of illness. But the recommendations are still to give it, and there's really mixed information because there's really no controlled trials of the drug. A lot of these are just large observational studies which are very much prone to bias. So people here seemingly have used Oseltamivir quite a bit. You take it for 5 days, twice a day. You can use it in children as young as 2 weeks of age. It's something that I think we're all fairly comfortable with. There are other drugs as well. Peramivir, for those of you who work in the hospital, if it's on your formulary, is IV for those who can't take oral and is a once-a-day drug. There's also Zanamivir. No one's used Zanamivir, have they? It's been on the market for quite a while. It's an inhaled powder, but I don't think anyone really likes taking inhaled powder when you have a respiratory illness. So it's really never taken off terribly well. But interestingly, has probably the highest activity against influenza virus of any of the compounds, and an IV formulation has been sort of adrift for a while in studies and regulatory processes. And then there is a new drug called Bilac that works very differently. As I mentioned, the neuraminidase inhibitors work by preventing the virus from leaving the cell. Bilac is an acid polymerase endonuclease. It actually inhibits the viral replication. So it actually, much more like an antibiotic or like a fluoroquinolone for antibiotics, acts at a molecular level to cease viral replication. So it actually works much earlier in the viral replication process. And it is only once taken once, and it's because the half-life of it is almost 80 hours. So it's just different than the Oseltamivir, and we'll talk about some other differences there as well. In terms of side effects, many of you know that you probably have to quote about a 20% risk of GI side effects with Oseltamivir, where the patient has influenza. That's not exactly a party if you're adding on, nausea, vomiting, and diarrhea. Peramivir has a little bit of diarrhea too. Zanamivir can make people wheeze and have complications. You're not supposed to use it in anyone with asthma. And then Baloxavir has a fairly clean side effect profile. In fact, in the placebo-controlled trials was no different than placebo, so very low rates. So again, even though it's an anti-influenza agent, it is a very different compound than Oseltamivir and has a different profile. So I thought I would just mention this new drug a little bit because everyone has a lot of comfort with Oseltamivir, and we can do a little comparing and contrasting here. So there have been a number of studies. This one is this drug versus placebo, just like we tend to use as an outpatient with Oseltamivir. So these are generally uncomplicated patients with influenza in the outpatient department. And compared to placebo, much like Oseltamivir, if taken within 48 hours, it does reduce symptoms by about a day. So that's probably a benefit for people that need to get back to work and feel improved. It's also been compared against Oseltamivir, and probably because it works at a much earlier part in the cycle, it reduces shedding much more dramatically than it does Oseltamivir. This is sort of interesting. We don't know the impact of it, but if I were an infection control officer in the hospital trying to reduce influenza spread nosocomially in the hospital, this could have some impact. And then from a safety standpoint, as I mentioned, the rates are much lower than you might see with Oseltamivir. The GI side effects are really no different than placebo, and they're in a lower percent range compared to the 20% that you might see with Oseltamivir. Now, using this drug in so-called high-risk adults, those who have had complications and serious illnesses, those patients have been studied, and they too have an improvement of about 24 hours if the drug's gotten early enough, like our case patient who probably is going to be hospitalized. It also reduces viral shedding, also with reductions in the use of additional antibiotics or complications, as you can see here. So again, as with all anti-influenza drugs, if you can take it early enough, the drugs work. If you're giving it later in the illness, which is of course no fault of the drug, the physician, or the patient, it may not have as much impact. There haven't been studies so far looking at this drug at day 3 or 4 or 5 and so on, so we don't quite know that information yet. And the drug was compared head-to-head in this higher risk population with Oseltamivir, where it worked fairly comparably, perhaps a little better in terms of influenza B, and with a similar side effect profile. And these are, again, in patients that tend to be sicker. So in this case, and just wrapping it up, a patient had a O2 saturation of 88%. She got sick in a hurry in 2 days. I think most of us would end up hospitalizing this patient, I think would be the prudent choice. She is the ideal candidate to get an antiviral compound whether it's an injectable Peramivir or one of the oral agents. And you always need to have on the docket whether there's a bacterial pneumonia. So I think almost always we end up giving antibacterials in severely ill patients, especially those given heading to the intensive care unit. Of course, in patients that don't need to be hospitalized, it's a bit of a toss-up in a healthy patient who's not severely ill, whether you use antivirals or not. And I think this remains a judgment call, and the shared decision-making that Dr. Mornay talked about in terms of understanding the risks and whether people want to take a compound and the potential benefits if you're seeing the patient early enough. So I think there's some time for questions. I know we went through a lot of information, but hopefully we gave a good overview of influenza, some of the diagnostic challenges, and really the message that if you can get antivirals into patients early, they're going to help. And that's a message sometimes for my higher risk patients, patients who I care for who have heart disease or asthma. I tell them, if you think you have the flu, call me immediately, rather than waiting until you're sick enough to call the doctor. So thanks very much. I think someone has a microphone that's going to come around. Is that right? There's a question there.
Thank you. Can you speak a little bit about prophylaxis for contacts or other folks?
Sure, yeah. So the question was about prophylaxis. And you know what? Where these antiviral compounds work the best is for prophylaxis, if you think about it. So anyone who has had contact with influenza patients, especially if you're high risk, you can offer chemoprophylaxis. What's been studied is Oseltamivir, 75 milligrams once daily. And usually for a 10-day period. So that's definitely an option. It does certainly prevent influenza. Obviously, you need to treat a large number of people because the attack rate of influenza is not 100%, even in a household. But I would certainly consider it for any high-risk patient that's in a household, most certainly. There are other questions? Yep. We're going to be coming around with the microphone there. We have one. We have 1, 2, 3 there. So,
would you comment on the pricing of Bilac and the availability and the insurance coverage?
Yeah, excellent questions. And it's quite new to market. I'm not sure the pricing. It is only one pill. It's obviously a branded one. So if anyone knows that information,
I see the average retail price of Bilac is $180. The wholesale price is $150 for that one pill.
Right. Okay.
So Dr. Mornay put up the slide for the various rapid and less rapid tests that we have. I was just wondering if we are ordering that in the outpatient world and then here in the hospital, which exactly test are we getting? And also, the similar question, what's the cost of that? Kind of informing that, do you just treat versus is the test worth doing?
Sure. Dr. Mornay can come up. I'll say that in the outpatient arena, the rapid is really all you can use because the patient's not going to hang around. If someone's hospitalized, we want to know if they have influenza because we have to put them on respiratory isolation and so on and so forth. So we'll usually order one of the molecular tests there. And the costs are obviously much higher for the molecular tests than the rapids.
Yes, what I would want to add to that is that because when we are talking about treating influenza, it's time sensitive. You really want to go with the fastest test and get the patient on the medication as soon as possible. The rapid test that we use in urgent care and in outpatient is not very expensive. I can tell you in urgent care here, it is included in the price of your visit. I think you will bill for it separately in regular outpatient visits. It's not that expensive. I don't have a number to tell you, but this will give you an idea how it is. Other tests that are being done in the hospital, it's a very different system, and they're a lot more expensive, of course.
And just to mention, if you know you have seasonal influenza in your community, as Dr. Mornay said, you're going to be, if someone has fever and cough, its accuracy is about 70% that you have influenza, which is about as good as a rapid diagnostic test. So when you know you have circulating influenza in the community, you have an influenza-like illness, you'll just make that clinical diagnosis without needing tests. So that's cheaper, but gives less precision, of course, potentially. There were some other questions?
Yes, we have one from our streaming viewers.
Okay, and then we have one there. Yeah.
Absolutely. We have the percentage of vaccinations slide stated it was the number of vaccinations at time of positive test diagnosis. Do we know the population percentage overall for vaccination?
So that was one of the Lancaster General.
I don't. No, I'm afraid I do not.
So, yeah, Dr. Raff doesn't know. Very good question. Thank you. There was a question here. Yeah.
A question again on prophylaxis. On Bilac, you did not comment on that, and particularly the CDC have guidelines for long-term care residents. As a nursing home medical director, I have to decide which medicine we use. So are there indications and durations for Bilac yet, or is that to be decided?
Yeah. So the FDA indication for Bilac is for ages 12 and older. So it was studied in the adolescent population and adults, but not in younger children, not relevant to nursing home populations, but it's only for a treatment indication. So there's not a prophylaxis indication. Now, the profile is pretty reasonable. So I imagine it probably will have abilities to offer prophylaxis, but there is not an FDA indication for that. So I think most of us, and also from an expense issue, would use Oseltamivir at 75 milligrams once daily.
My experience has been that a isolated family member may catch influenza that maybe they didn't get last year, and then the rest of the family freaks out, and so you just kind of wait and see, who's going to get it. What do you tell your patients as far as transmissibility of the virus, viral shedding, how long that occurs?
Yeah, so it's really variable. So most people, the shedding is pretty much over by the time of clinical improvement. So 5-7 days, that's demonstrable. If you start doing molecular testing, you see the virus a little longer. We don't really quite know what that means, whether you're still capable of having an infectious illness. I've had a patient with AIDS, for example, shed it for 3 months, very interestingly. So it depends on your level of immune response and clearance. That scenario is very common, and I think that's where you sort of take, if you had one of those patients in the hospital had congestive heart failure, I'd put that person on prophylaxis. For others, you could take a wait-and-see approach, and at the moment they have their first symptom, just say, call me, and I'll give you the antiviral compound. But, the option is still to take prophylaxis as well. As I mentioned, in Japan, it seems like you get sushi and Oseltamivir, with lunch, perhaps. So the use there is much higher because I think the awareness is so much higher, and people don't want to get ill, and so on and so forth. So they use much more of the drug there than we certainly do.
We have another question from streamers, and then I'll pass it along. When do I need a chest x-ray, or what symptoms would prompt follow-up tests, such as a chest x-ray?
Sure. So when do you need a chest x-ray? So this probably comes more from the emergency room and urgent care literature, where basically if someone has a chest cold and you have generally normal vital signs, you do not need a chest radiograph. I would say if you have abnormal vital signs, if you're tachycardic, elevated respiratory rate, that's where you want to get a chest x-ray. Pulmonologists have looked very carefully at whether auscultation and percussion correlates, and sadly our physical exam abilities to correctly diagnose pneumonia are not very good. They're in like the 30% range. So you do need a chest radiograph if you have a concern. But if someone looks relatively healthy and has reasonable vital signs, you don't need to get a chest x-ray. There was a question in the middle.
Back to flu testing. Just to bring up the question about molecular tests, just because it seems much more accurate. I've been trying to, been trying to pursue maybe looking at doing molecular testing in the office. Just wondering, has that been pursued anywhere? Is it just a matter of the cost is too much, or is it purely just the wait time is too long to make it viable?
I think it's on two bases, cost as well as weight, but people have looked at offering molecular testing at point of care. And obviously, especially outside of seasonal influenza, when you have an influenza-like illness, you don't know if in November if it's the first case or not. It makes some sense. But I think the pricing and the time will have to come down. Do you want to have a platform that, you know, can do a rapid molecular test? Interestingly, a lot of these testing platforms are being developed for low income countries in Africa and elsewhere, for example, tuberculosis and so on. So people are looking at sort of more simple, like lateral flow assays and so on, beyond the molecular test to try to get that question. I think we will get there. So we'll have some better testing. I mean, already, if you look at something like the BioFire film array for respiratory, I mean, you get this amazing panel that will tell you about viruses and bacteria as well. You know, that's something which we still have to figure out how to use properly. So, you know, we're moving away from our very old-fashioned culture-based systems and so on. So I think the day will come, but it's still some years away.
Could you comment on hospital employees and viral shedding? Like, how long should a nurse, doctor, APP either not be working or working?
Yeah. Yeah. So there are a number of guidelines out there, and each are a little different. So I don't want to. We could probably look up what the LGH policy is, but typically you would like to have people improved for 48 hours after, you know, so no cough and so on. And then, you know, we see doctors and nurses wear masks and so on. So obviously, how many patients actually get, or healthcare workers get diagnosed versus just have a clinical suspicion is always a little difficult to know. But, you know, the virus can be on hands and so on and so forth. So that's why it's still important to use Purell. Yeah, you know, there's been a long-standing effort to try to get workers not to show up at work ill, so you don't all get infected. The American work ethic is still there, so I think it's a challenge to keep ill people at home, although working from home is more common. So, you know, we can't do that as healthcare workers, though, can we? Okay, I think we're close to our hour, so I'll hand this back to Dr. Rapp.
Thank you very much. Thank you very much, Dr. Allwater and Dr. de Mornay for DKB Medicine for helping us to put on this, project here. Remember to do your post-test. Those of you that are online will be getting the post-test via email. And this is just a summary takeaway. Obviously, the annual flu vaccination is the most effective way that we have. And the health belief model may help us, particularly those of us in primary care, to be able to bring our patients to the point where they appreciate the value of getting immunized, and can be very helpful for a lot of other things that we treat people for as well. Antiviral therapy is most effective within the first 48 hours. So unlike many of our patients that we tell them, ride it out, it's only a cold, don't call us the first day. With this set of symptoms, we need to hear early if we're going to be able to do anything. And then consider if you're going to treat, use those antivirals early, particularly in the high-risk groups that Dr. de Mornay listed. So thank you very much for being here. The CQI project that I mentioned for LGH, primary care people with the 20 hours of credit, if you have interest in that, please contact myself or Dr. de Mornay. We can tell you more about that. All right, and here are the phone numbers, the email connects if you need them. Have a great day, folks. Stay well.